You will hear today a number of very sophisticated EBM lectures, and I decided to go the other way and make it as simple as possible. And the reason why I wanted to make it as simple as possible was dictated by my encounter with the patient in intensive care about a month ago. When I read the entry into the chart, it looks like this. And I was looking at it, and I had to call my colleagues to explain it to me, so I tell you, it says, history of present illness, community-acquired pneumonia, past medical history, recreational marijuana use, that was something, intravenous drug use, coagulase negative staphylococcal sepsis, percutaneous nephrolithotripsy with course in hospital, including acute kidney injury, ventilator-associated pneumonia, and use of biphasic positive pressure ventilation, and today AWOL, which means absent without leave. I figure out it's quite difficult to understand it, but then I reflected on what we do with EBM language, and I want to share with you, I took the first article which came into my hand from New England Journal of Medicine, and that's what it said. RCT with concealed and stratified randomization and block size of 8, with HR at 95% CI generated with the use of Cox proportional hazard model of stratification factors as covariates, and p-value for time to event analysis calculated with long rank test. Well, they added to it that heterogeneity was with I-square of 65, and thankfully there was one sentence I understood which was more research needed, which is probably how it usually ends. So what are my goals if I don't, and I figure out that it's probably worthwhile to talk about a very simple concept. And from my Peruvian colleague, Victor Montori, I learned that matrix is not matrix, but matrix. He is an expert on English pronunciation. These are the things which I would like to share with you. Concept of matrix, concept of PICO, concept of confounder bias, and talk about money and wealth in the end, so please don't leave before I finish. Now, before we start, I wanted to ask you, I see some, who would like to talk about statistics today? I see 2 hands up, and it actually follows what you see here, the father of evidence-based medicine, Dr. Gordon Guyatt, who coined these terms years ago. But this is a quote from grandfather of evidence-based medicine, Dr. Sackett, who said that after 7th course of statistics, normal clinicians know as much about statistics as before the 1st course. And the reasons was that mathematical formulas are impossible to remember, that statistical techniques are totally isolated from patient's care, and that mastering them even for a short time requires sacrifice of family and social time, lowering of self-esteem, and total loss of sense of humor. So if we are not talking much about statistics, let's talk about this concept of matrix, which I would like to sell you on. The concept is that anytime you approach a clinical question or research question or publication question, you could go by 4 questions. The first one is, are you interested in it? And you will repeatedly probably hear today about PICO. The second thing, if you decide that you are interested, is to see, can you believe what's in front of you? Then you are looking at the result. And if I can suggest something, despite what I told you about statistics, I would like to take you through a whole course of statistics now. All statistical techniques allow you to look at the differences which you are observing, and those differences are usually in form of means or proportions. And then the question which every statistical techniques ask is, could those observed differences, or larger than that, occur by chance? And there is one letter which describes the probability, and this letter is P. So this is statistical course which we'll finish right now. And then you are looking at clinical importance of results, and that's what Gordon was talking about, absolute reduction, what's the baseline risks, how many people you need to treat to avoid one event, and so forth. So this is the whole matrix, and I will show this slide over the next 15 minutes, probably 5 times. So the first one is asking clinical question, and I'm not sure how many Polish people are here, but there was a small East German toy, which was a train toy called PICO. And this is how I remember it, because every question which you are asking should include population. It's different for 80-year-old with large infarct and 40-year-old with small. Intervention, different thrombolytic therapies, and now we have percutaneous intervention. What is the comparator, and what is the outcome? And we could give an example of each of them, but I want to show you one. This is an advertisement which I've seen years ago of use of one of the antiarrhythmic drugs. It sounds to me like we are really antiarrhythmic set, but this was about the use of antiarrhythmic drug, a specific drug after cardiac arrest. And the advertisement said that if you get this drug, you will go in the ambulance to the right to City Hospital, and if you didn't get this antiarrhythmic, you will go to the left, which is City Morgue. And obviously, most people would like to go to City Hospital rather than to City Morgue. However, the idea here was that even though you get to hospital quite a bit more often, you will not necessarily go home anymore with any more probability that if you didn't get this drug. So this is kind of a description of the situation where the answers you will get will depend on what outcome are you looking. If you want to get to hospital, that's fine, you should take the drug. If you would like to go home in a reasonable neurological state, it probably doesn't matter. So that's the PICO. This is the first one which I wanted to sell you, and I'm coming back to the matrix and PICO. So we already fulfilled first two of my goals. Let's talk about confounder and bias, because these are jargon words which we throw around, and I would like to make sure that we have similar understanding, hopefully proper one. And this is at the idea of, can you believe it? When you are looking at the concept of matrix, can you believe, or in jargon term, is it valid? So I want to tell you, as I learned from Gordon, evidence-based medicine is about telling the anecdotes about how not to tell anecdotes in medicine. This one is the story of laparoscope of the surgeon, thoracic surgeon from my hospital, who about, I would say, 15 years ago decided to do first laparoscopic resection of esophageal cancer. This surgeon operated on this patient, I still remember it. Unfortunately, about 10 days later, the patient died. The surgeon was very upset. He got a little bit better after he published it as a case report. The question is, why did the patient die? And we were all saying, don't worry, this patient, really nobody else wanted to operate on this patient. He had major coronary artery disease, chronic airflow limitations. This is patient's fault. We probably all know this kind of explanation. So now he was a little better. He went on, operated 5 more people, and after 6 months, 4 out of 5 were dead. He was really worried at that time. However, again, improved his well-being by publishing it as a case series. And the question again was, why did these patients die? And again, the idea here was that they died because they were old, they had a lot of comorbidities, because nobody wanted to operate on them in a regular way. So that comes to these factors which influence outcome. The idea is they didn't die because the surgeon was bad or the surgery was bad, but because the patients were bad. So we frequently blame patients for when some things happen, but in this case, the idea was they were all much older, and their prognosis and their death was determined by the fact that they were old, not by the fact that they were operated laparoscopically. And those factors which influence outcome in the epidemiological, if you wish, or EBM jargon, are called confounders. And those confounders lead us to conclusions which are systematically different from the truth. So I could go a little bit more, and now the patient, he operated on 10 patients and compared it with 10 patients whom he operated with a normal technique a little earlier, and there was a difference in mortality, and if you wish, you could call it a cohort study by now with historical control. And the question is, were these patients identical? Could we compare them? Is their care the same? Again, the issue of confounders, which we call unbalanced, because they may have different age distribution, different distribution of advanced disease, and so forth. And if we have the imbalance of confounders, again, I'm trying to make those two common understanding among us. If you have this prognostic factors, if you wish, or risk factors, or confounders in this case, if you're comparing populations which are different in their distribution, you will get not valid result, or other word for it is biased or not true. So the whole research methodology is effectively designed to balance the confounder. How do we do it? We want to achieve a situation where groups which we compare are similar or identical in respect to distribution of those confounders. And one of the definition of randomization, probably not the best, but the simpler, is to achieve the situations where getting or not getting the treatment depends only on chance. So what I would like to stress from this segment is the issue of confounder and bias. So we've done the three things here already. And now we are talking a little bit about money and wealth, and this is again in the area of what are the results. So we are moving along the concept of matrix. Now, what I would like you to think, these are actually Canadian gold coins. Each one has nominal value of $1 and sells probably from 200. But let's say that before lunch you have 20 coins, and I would like you maybe to pair with the person sitting next to you and make sure that you answer the questions which I'm asking to each other. I promise I will not ask any questions. You had 20 coins before lunch and 10 coins after lunch. The question is, how much money have you spent? 5 seconds to answer the question. All right. What is your absolute wealth difference here? 5 seconds. Please confirm with your colleague that you have the same answer. What is your absolute wealth reduction? Everybody got 10? All right. Now, what is the proportion of wealth you still have? You had 20, you have 10. What is the proportion you still have? And what is the proportion of wealth which you have lost? And obviously you are seeing that in the end, whenever you forget about those absolute risks and relative risk reduction, try to change it into money of your own country, and it usually goes easier. You see that proportion of wealth you still have is 50%, so the rest you lost, so 50 is lost. And what is your relative wealth now in comparison to where you were before? If you found that it's 50%, your relative wealth reduction is another 50. So let's make it quite a bit more complex. You are before lunch, you have 4 coins, and after lunch you have 3. How much you spend? That should be easy. What is your absolute wealth difference or wealth reduction? What is the proportion of wealth you still have? Everybody agrees that it's 50%? Excellent. It's not 50%. Okay. I'm just checking. What is the proportion of wealth you have lost? Well, spent. 25. What is your relative wealth now in relation to before lunch? Still 3/4. It's still 75%. And what is your relative wealth reduction? You still have 75, so you lost another 25. All right. So, again, with your colleague, have a look at risks now, not at the wealth, but at the risks. Before intervention, you have a risk of 20. After intervention, you have a risk of 15. What is the absolute amount of risks removed? To make it easier, I tell you that it's 5. What is the proportion of original risks which remains? You still have 15 out of 20. Still have 3/4, you still have 75%. And what is the proportion of original risks removed? The proportion which is left is called relative risk. The proportion removed is relative risk reduction, and they have to add to 100% or to 1. Now, the other thing which sometimes confuses people is we talk about relative risks, but sometimes the idea of the risks in one group versus the other is presented in either odds ratios, which I will not talk here about, or hazard ratio. And the simplest and possibly simplistic way of looking at it, that both of them approximate the best we can say our approximation of relative risks. As you could see here, the hazard ratios is used because if you have a survival curve from a cancer, those curves separate by different amount in different times. If you go long enough, everybody is dead. If you start early, there is a benefit. What you are trying to see is how much better is to be on the upper curve and on the lower curve, and that's this hazard ratio of 0.68 estimates where we are. Okay, My last two comments, last two subjects are dealing with concepts of meta-analysis and then network meta-analysis. Usually people go for 3-day workshops on those. We'll try to do it in 4 minutes and 50 seconds. So you know about importance of clinical question. And when you ask yourself a clinical question and choose your evidence whichever way you want, you are ending up with a review article. But if you go a little bit farther and increase the methods to increase and use the methods to increase believability of what you do, that means pick up all subjects, all valid primary papers on a given subject, you will get something called systematic review. And if you apply on top of that the statistical tests to analyze the importance in a statistical sense, the probability that observed differences are due to chance, you are having something called meta-analysis. So I show you my summary slide of meta-analysis. You have a meta-analysis, and you take lots of primary studies, which better be answering similar PICO, and you are ending up with a result. And this is all what I would like you to know about meta-analysis at the moment. You've seen this slide in Gordon's presentation. This is the slide where there is a line of no difference, and then usually to the left of it there is a preference for one of the treatments. The results by now are all, you are familiar with statistical course. They are in terms of proportions of people suffering an event on one treatment versus the other. Then you usually have presentation for all of them, and you could see that there is about 22% risks of vein thrombosis on placebo versus 8% risk thrombosis on active treatment, and I believe you will see those a little bit more when we talk about meta-analysis down the road. Now, the last segment here. You have 72, not 95-year-old person who is feeling unwell for the last few days with cough and dyspnea, confused, low blood pressure, high temperature, high white cell count, and chest X-ray showing pneumonia. Who would give antibiotics to this person? Hands up. Okay. And who would give fluid right away for the hypotension? Hands up. All right, most of you would. Now the question is, which fluid? And you know, for last several years, people were debating whether the fluids to give those people should be simple crystalloids, normal saline, Ringer's lactate, Ringer's acetate, or whether they should be colloids in a form of albumin, starches, gelatins, and so on. And this debate was raging a lot, but in reality, it's not fluid, it's not colloids versus crystalloids. It's a lot of different crystalloids, which are blue and the top. So you have normal saline and balanced crystalloids versus a lot of different colloids, which could be hexamino-starches, gelatins, albumins, and so forth. So when you look at the study results, which happened over the course of last few years, there was plenty of comparison between normal saline and starches and plenty of comparison between what we call balanced crystalloids and starches. So you could compare them this way. The question is, could you compare them this way if you wish to compare those two indirectly? This comparison exists in a direct sense. This comparison is only in indirect sense. Or making it even more complex, you have all the trials which happen. So this would be balanced crystalloids versus hexamino starch. This would be albumin versus saline, and so forth. So this represents how many studies on a given topic are available. But in reality, you are interested in this comparison, which has no direct link and no direct studies. And this is a nature of what is called now network meta-analysis, which whether you like it or not, you see, and you will see a lot, because that becomes the new way of expressing efficacy of treatment. And you could see that at least in this example, from indirect comparisons, network meta-analysis estimate of relative risks is 0.78, so 78% risks persist, with balanced crystalloids theoretically saving about 22% of death which would otherwise occurred. And it also, in network meta-analysis, you will find something called a ranking, and there will be numerical values, which I just want to put up that you don't consider 84% to be 4 times better than 24%. It simply gives you a rank which tells you which one are considered better than the others, not necessarily about how much better. So I would like to finish here. I'm 5 seconds over. I want to remember you about concept of matrix, that's what we were talking about, PICO, how to believe them, what are the results, and I will finish from the slide from Canada to give you a little bit break.